We are live.
A very good evening, everyone. Welcome to iFocus Online, Lecture 258, Ophthalmic Trauma Module, Lecture 3. Today we have with us Dr. Mehul Shah from Drashti Netralaya, Dahod. Sir has been with us as a chairperson for this module for the last two talks, and looking forward to his talk today on corneoscleral trauma and traumatic cataract. Dr. Mehul Shah has done his VR fellowship at Shankar Netralaya. Currently, sir is a medical director at Drashti Netralaya, Dahod. He has numerous publications to his credit, almost 1,000 national presentations and 150 international presentations, has authored 2 books and 10 chapters in different books, and he's on the editorial board of 3 international journals. He's also a passionate teacher and has trained a numerous number of DNB residents, short-term and long-term fellows, optometrists, and nurses. Also, he has many awards in national and international conferences to his credit. Looking forward to sir's lecture today. Over to you, sir.
Is my slide visible?
Yes, sir. Visible, sir.
Yeah. So I have 2 things to talk about. One is the corneoscleral injury, its management. First of all, as an introduction, it is very important to understand that many of the private practitioners and some of the people, they do understand that ocular injury is untouchable thing. And of course, we all know that in some or other percentage of ocular trauma is coming to the day-to-day practice, whether it is a trivial or it is a severe. But we wish all ophthalmologists should have some understanding of ocular trauma. Slide is not moving. Okay. So most important thing is we have to understand there is a very old classification of 2006. This is a BETTS classification. It was first introduced by Dr. Kuhn et al. And it has been divided into open globe and closed globe. All this has been covered by Dr. Purendra in his talk. So I'm not going into the detail. So when we talk about corneoscleral injury, we need to look at the open globe injury and whether there are laceration, rupture, or penetrating trauma which we need to handle. He also discussed about the prognostication about the ocular trauma score and pediatric ocular trauma scores. But with current introduction of toddler ocular trauma score, which is under 6, which is very different, which recently published in IGO. And everybody has to understand that. Score, which is under. Hello? The toddler ocular trauma score is for 0 to 6 children to prognosticate the outcome of the ocular trauma. And when we look at the open globe injury, we have to understand the zones of ocular injury in open globe injury. When we see if it is a corneal trauma, it becomes a zone 1. If it is between limbus and 5 millimeter from the limbus, zone 2, and beyond that is zone 3. We understand that if the injury is beyond aura, the prognosis is poor, and the strategies to how to tackle it, it's very different. So when we look at the trauma, we have to start working either from limbus or cornea or sclera. When we start the corneal repair, it is important to decide about the location, depth, and shape. Either it can be linear or it can be triradiate or irregular. Debridement, as Lavenbelli says, that for any wound healing, debridement of the wound is very, very important. When we see the patient, we see many more tissues are coming in between the wound edges. Like either it is a iris or lens material or vitreous. We need to debride that. We have some innovative techniques for the debridement. I'll demonstrate this. We use the vitrectomy probe for the same. And you can see that how the wound is clean. When you clean the wound first, then the suture, we can see the edges which can be opposed very easily. The another innovation which has come, vitrectomy cutter can be used. Another innovation is the entry chamber maintainer. As it is very well documented that my viscoelastic into the open globe injury is very dangerous, causing severe secondary glaucoma postoperatively. So there is big controversy going on whether to use the viscoelastic or not. So, but when we use the AC maintainer, we have advantages that it will wash off the hemorrhages, it will create the space for us, and it will prevent further damages so that we can handle. And this is how we remove the hyphema using vitrectomy probe. We can see that it was a zone 2 injury and sclera was very irregular. We sutured sclera and the child has become normal, almost normal. Probably the child will require a cataract surgery later. So when we do the corneal suturing, it is very important that we have to understand normal, the suture material, what is being used is 10 monofilament nylon, 90 to 95% depth passing from the stroma, corneal stroma, and shallow suture will cause, this is the perfect position. We have to see the 90 to 95% depth of the cornea is being involved, and suture knot is to be buried because nylon is the suture where the corneal epithelialization can occur over it. So it becomes a less symptomatic for the patient. When the sutures are shallow, it will cause posterior corneal wound gap. And if the suture has got unequal depth, it will cause overriding. If the suture passing through unequal length, that also will cause the overriding of the cornea. And if the suture is full thickness, it will create a track for the infection, and there are chances that intraocular infection may occur following this. Important is to understand how to manage the uveal tissue which is prolapsing through the wound, because uvea is again a policeman of entry chamber, like omentum is a policeman of abdomen. So wherever there is a gap, iris will come and plug that area. So if in our country, patient may present late, if patient is presenting early within 24 hours and looking at the settings, if the object is more contaminated, if coming from long traveling, then we need to excise the uveal tissue, or we can deposit the uveal tissue by from the side port using the iris repositor. This is another video where we have a linear cut. We use the AC maintainer, use the vitrectomy. We can see the fluid is free flowing. So we know how to oppose. In between, if the things are prolapsing, we can cut it with the vitrectomy. Once we repair the wound very clearly, then we can go ahead and do some further management for visual outcome. But if the wound is open, there are fair chances that there can be intraocular infection, which has to be prevented. And these are the things, if possible, can be done under topical anesthesia. If not, then we can do have a general anesthesia and repair the wound. Because peribulbar block is almost contraindicated, which may cause the expulsive hemorrhage. And during COVID, we had to have a very due precaution, because when you do the general anesthesia and when you intubate, there are chances that you can see that the microleakages also are visible. Thank you. then it is important to understand that there may be blunt object when it is hitting to the cornea. It can cause triradiate or multiradiate wound. So either we can repair all arms and then seal the central area with the tissue glue, or we can use the purslane suture. Both the things can be done in different scenario. We can see here one small triradiate and one arm is along. So creation of side port is like a we released all uveal tissue. Debridement done using vitrectomy, and long arm is sutured. And shorter arms also sutured for the linear components. This is another case where we have a triradiate injury. And here we are, this is under topical anesthesia. And another is the purse string suture. This is how we can seal the triradiate wound. Another important thing is scleral repair. When there is a scleral repair, we all have to be very, very clear about the scleral repair. That is more serious problem, and majority of the time it is combined with corneal as well as scleral. So we consider it as a zone 2 or zone 1+2 injury, which is not beyond 5 mm. And reaching to the, we have to suture it right up to the posterior extension and reaching to the posterior end of the wound, which is very important. In the process, many of the time we may need to disinsert the rectus muscle. Again, debridement will be the first step, because when we have a zone 2 injury, we know that there is injury to the ciliary body, and ciliary body injury have bleed profusely. The material which is being normally is 60 vicryl, and first suture is to be taken at the limbus. Then we can use the zipping technique of wound closure as we go posteriorly, and we leave that one end of the suture so that we can rotate the eyeball and use it as a traction suture. Sutures in close proximity oversewing the uveal tissue. Debridement is the must. Excision of uveal tissue or excision of vitreous. If there is a prolapsing of the retina, if possible, we may push the retina back and cut the vitreous around. We can see this zone 2 phacocyl. This is a cattle horn injury patient. Patient presented with the phacocyl. You can see the lens is out. So we need to explore the wound. We don't know how long the wound is there. You can see the wound is almost 180-degree extended. And debridement done following vitrectomy. Not going into the detail. Sclera is sutured. We have secured the wound. Now there is a hyphema and vitreous into the antechamber. We did the vitrectomy, removed the hyphema, cleared the optical zone. And this was done into the primary setting, and later on scleral fixated IOL was done, and patient is doing extremely well. These are the zone 3 sclopetaria. As we all know that when there is a severe injury in cornea as well as sclera, that makes it a sclopetaria, and we see that how this patient presented to us. Very spoon, retina, everything was prolapsed. We tried to oppose the thing, but we could not. When we tried to see and explore, we can see that the whole conjunctiva was there in the vitreous cavity. And obviously, patient was no perception of light. We can see that we retrieved conjunctiva from the vitreous cavity. Then we could find the edges. We repaired this, and this was the end stage. Following this, the retina was almost right in the antechamber, which we operated, and patient regained at least 1 meter vision. The sclera is the thinnest behind the muscle insertion, and thus careful exploration of this area is very, very important. And in cases where the extension is beyond, we need to disinsert the muscle, suture it back, and then reinsert the muscle during surgery. There can be comorbidities, uveal tissues in the wound, foreign body, hyphema, cataract, or vitreous in the wound, which we need to handle later on. But there are some of the emergency things which we have to do during the primary repair. As we see, this is a foreign body. This is a large foreign body. We can see here, metallic. This is big. We removed that foreign body. We did the vitrectomy, removed all exudates, given intravitreal injection, and did the patch graft. This is the hyphema. This is the video of a time before we started using the AC maintainer, but we can see that after irrigation we removed all the tissues, did the vitrectomy, removed the vitreous because lens was dropped and vitreous is prolapsing. We cut the ciliary body. Sutured atralimbus. If AC maintainer would have been there, we would have dealt the hyphema in much better manner. But again, we removed the hyphema and then would get the. So it is very important controversial debate whether viscoelastic is to be used or not to be used We do not use viscoelastic in any of the open globe repair. So post-operative management, if it is depends upon whether there is infection or not. If it is infected, then we cannot give topical and corticosteroid. But if it is not infected, we have to give topical and systemic corticosteroid and topical antibiotic. Prophylactic antibiotic in case of patients who presented with the larger wound, came very late, or a patient presented with in the settings where there can be more contaminated things. Thank you. So this makes the part of corneoscleral injury. If we can take the question, or else we can take the questions later. Then second part is the traumatic cataract.
Sir, I think you can finish up with your lecture, sir. Then we can take it together.
Okay. Can you see the screen?
Yes, sir.
So traumatic cataract, again, the name itself frightens, and everybody has to understand you are not worried about the cataract because everybody does the excellent surgery with the cataract. Now, what is different with the traumatic cataract? It is important that to understand that why it is different. First of all, it has got a large social and economical burden because this condition occurs in a younger patient. So almost 77 billion US dollars are the economical impact by traumatic cataracts. Important here, it is a important cause of monocular blindness, and there are comorbidities. When there is injury, there can be comorbidities in intersegment, postisegment, and all the structures of eye can be affected. So even if you perform a great cataract surgery, there are chances that we may not regain vision. That is the reason unpredictability we all are worried about. There are certain challenges in younger children. Maintaining optical clarity is difficult because even after doing primary capsulotomy, vitrectomy, there are chances that patient may develop the secondary membranes again and again because of recurrent inflammation. And then if the child is under 5, there are chances that despite of our excellent surgery, amblyopia will be important factor. Difficult to assess the visual acuity every visit, and amblyopia may set in as the other eye is normal. And if we do not manage amblyopia well, then despite of our all efforts, vision may not recover. Another thing is to understand, like we have a very classical morphological classification of the cataracts, nuclear, cortical, anterior polar, posterior polar, but which is not the case with the traumatic case cataracts. It present with the various morphology. And it is important that we have to target these cataracts according to the morphologies. And morphologies, we see all these morphologies, you keep seeing every day in the OPD. But important is to analyze why it is so. Because those morphologies changes are dependent upon the type of injury and time interval between injury and presentation of the patient eyes to the surgeon. So that depends upon various inflammatory changes causing synechias, causing absorption of the lens material and leaving the shape which you may not like to operate. So we published this article according to morphology of traumatic cataract, does it play an important role in final visual outcome? So again, my type of injury will be very important because morphologies of open globe injury are different, morphologies of closed globe injuries are different. So with closed globe, we may find this total cataract, which is not going to occur with open globe injury normally. And with open globe injury, we may have a penetration of the anterior capsule, free, fluffy, flowing lens material into entry chamber, causing secondary glaucomas, and then patient may present with pain, patient may present with high intraocular pressure. So this we see is the normal we get into the children, because in our country there is a large population of Elotica, Elacia nilotica, which is called bubble thorn, which causes large number of injury in our patients. So in these cases, according to the examination, when we see that the whole anterior capsule is affected, we did not do any capsulotomy, tried to remove everything from the pre-existing opening. Lens is implanted in the bag because we want to ensure for longer period patient should not be suffering, and with single anesthesia we are ready with the setting of primary posterior capsulotomy and shallow anterior vitrectomy. This is what we term as a vitreorexis. We make the central opening. So this is another same case. Will not go further detail as it is the same. Important is when patient presents very late. It is very much possible that patient considers that since it is injury, the eye is lost. They may not go to any of the hospital. This particularly occurs in the rural area. When patients are found or patient comes to the hospital for some other purposes, then we may find this morphology. So it is because of absorption of the lens material and fusion of anterior and posterior capsule. The challenges here is when we start doing something forcefully, we may break up the zonule, and it is extremely difficult to perform phaco in this patient because it is not really the hard cataract, but it is a VT. So better we have approached to irrigate the patient. You can see there was a fibrosis here. So primary posterior capsulotomy and shallow anterior vitrectomy is being done not even in pediatric patient, almost in all younger patients, so that patient will not suffer of after cataract, because in traumatic cataract there will be condensation and inflammation of anterior vitreous. And if you don't perform that, then the patient will come after some time despite of systemic steroid. And if this is another, all are familiar with the rosette cataracts, and that develop little late. When we say something, when we repair and tell patient that everything is fine, you can go home, patient may come after some time with this condition. And so that we have to take the things in with very clear understanding in the mind. So overall, when we understand the surgical technique, either it can be lensectomy, vitrectomy, anterior or posterior route, aspiration of unimanual or bimanual, membranectomy plus vitrectomy, anterior or posterior route, lens delivery or oblique phaco and vitrectomy. Primary posterior capsulotomy, intersegment reconstruction can be done in very late presenting patient. So here we see the patient is presented with the traumatic cataract and vitreous hemorrhage as well. So we did the vitrectomy, removed the traumatic hemorrhage, vitreous hemorrhage. Then we did the intralenticular aspiration through pars plana route. Remove the posterior capsule. Anterior capsule is intact. We did the central opening in entry capsule and placed the lens over it. You can see the central opening in the posterior capsule. Patient is doing extremely well. This is another situation where we find this patient with the cirrhosis bulbi and could not identify. But when we taken patient in for cataract surgery, we could see that this big foreign body was found. We performed the cataract, inserted the lens, and patient is extremely well. But it is important that it was done in time. The posterior segment was not affected, secondary glaucoma was not there, so patient regained vision. These are the neglected patient, again, which presented to us after years of the ocular injury. If we try to do something forceful, we tried to do the entry capsulotomy and all material removed using vitrectomy, leaving the peripheral rim of the capsule intact, and use the sulcus fixated lens. This is another case. Here somebody operated and we can see the lens is subluxated. We did the vitrectomy and relocated the lens. This is a subluxation. What important step here we altered is we use the CTR ring before doing phaco. Since the patient has presented late, even in 36 years of age, nucleus has become hard. We could not aspirate. This is the situation many of the time we get. We thought we are thinking that everything is right, but we can see the development of tough membrane behind the lens again. So we need to intervene again and do the membranectomy. This is a very common condition in children. Even if we have performed the primary capsulotomy, then also this can happen. And it is very important for us that we have to keep tracking this patient. If we leave the follow-up, this always will happen. So we are talking about visual outcome. I think some of the things are beyond the scope of this class. So epidemiology, we have a data of 1630 traumatic cataract, supposed to be the highest series. And these are the statistics, and out of that, we can see that 664 were the pediatric. So mean age for general database were 27 years, and mean age for children were 9.7. Poorest of poor will have more impact of the ocular injuries because their social condition and is such that they will have a injury and they will not have access to the proper treatment. This is what we have published, that ocular injury impact of ocular management. And when we compared the pre and post vision, we found the significant difference, obviously. And type of injury in 1630, we compared the open globe and visual outcome in open globe and closed globe injury. Both are published. One is Graphes, one is European Journal. In children, we found that closed globe injury is doing better, and in open globe, we found that in adult, it is open globe injury doing better. So stone and wooden stick are the mainstay in the as an object of injury. And we published 2 articles that despite of wooden stick injury is a vegetative injury, which is well known, but bubble thorn is the wooden stick which is more commonly involved in our country. We got the chemical analysis of that, and we found that some many antifungal and antibacterial element in that, and we published this article in the Journal of Pharmacology. So despite having large number of wooden stick injury, we had a very minimal percentage of ocular infection. And when we look at the tissue as a comorbidity, cornea was the most commonly affected tissue in 61% of cases. And when we calculated the number of tissue involved, we found a significant difference, like 6 tissues involved in only 0.3% of cases. So 2 tissues involved almost in 50% cases. So activities during injury in children, playing was the most important. We compared the etiological outcome amongst the children. The traumatic cataract children are doing much better than the congenital cataract, because in congenital cataract and very young children, the sensory nystagmus is important factor, which is not there. In traumatic cataract, visual system is fully developed, and if we do it promptly and correctly, then chances that that child will have a better development, better vision. So almost 50% gain, more than 6.24% after surgery for traumatic cataract in children. Another study is important, the intervention of time. We all know that it is a very common thinking and understanding that sooner the better. But we always operate in 2 stages. First is the repair, and then second stage will be the cataract surgery. We found that if we operate with cataract between 2nd week and 4th week, so 15 days and 30-day outcome was the best. And as I said we published this in IJO, maximizing visual outcome in traumatic cases, the value of primary post-capsulotomy and anterior vitrectomy. When we did this step, our outcome has become has improved, and recurrence of the secondary cataracts and secondary membrane was minimal. It is important that which anesthesia we use in the children, particularly for trauma. We published this article that when we have combined the general anesthesia as well as local anesthesia, regional anesthesia, which has given much more safe and easy anesthesia for ocular injuries. Now, when we consider the rehabilitation, many of these children did not have zonules, did not have any support for the lens. So how to rehabilitate this patient? As we all know this, it is very common that intraocular lens is the first choice, but may not be possible in many cases. So contact lenses, glasses, patching, strabismus, all this will follow. So if there is no support, we use aphakic glasses, but these are the children where trauma is mainly monocular. So it is extremely difficult for us to manage monocular glasses because child will never wear the monocular glasses. So another option was contact lenses. Then third option was the entry chamber lens Kelman or any other design. But already compromised eye, if we go for AC lenses, there are many changes will not permit eye to remain quiet for longer period of time. So there are other options, iris glow lenses, either posterior or anterior. But again, it has got its own implication. Many of the trauma cases, we have a poor iris, we don't have iris support. So that these options also may be for iatrogenic aphakia and not for the post-trauma aphakia. So we found out this solution.
We have no financial interest. Complicated, effortless technique of the Rana and Shah's self-sustaining scleral tuck IOL. Scleral tuck IOL is designed to simplify the complex surgery of scleral fixated IOL and reduce the cost significantly. This design of next generation of scleral fixated intraocular lens advantages of scleral tuck IOL. So we retrieve these flippers out from the sclera and leave it like this. So this is a major breakthrough in surgical implantation of scleral fixated IOLs. It can work in any trauma cases, in any. As the name says, it is self-sustaining.
Disfigured sclera.
There is no need of non-reusable materials like suture or glue. Simple in design, easy to implant. It is foldable.
This is the girl which is 7 years old, presented with no perception of light. No perception is not the contraindication of surgery in modern traumatology.
Anyone with knowledge of anterior
according to EVS, we applied EVS.
No need of sutures or glue.
The infection was controlled.
It is cost-effective.
Vitrectomy was done.
Larger optic, which is large enough to cover even a mesopic pupil, and even in a case of misalignment of sclerotomies.
Disc and macula.
Haptics have 4-point fixation, so minimal pseudophacodolysis. Flipper is rigid to stay in the position for longer time. Less surgical time, less corneal damage, hence good.
Then we have taken for this scleral fixated lens. You can see the flaps are prepared like any other scleral fixated lens. We inserted lens into the entry chamber. It has got very small learning curve. It is a 23 gauge opening. By holding the flipper is retrieved outside. The other side. And it's done. This remains in longer period. We are following up this patient since last 2 years. And the girl was no PL. She is having 612 vision. So this is how, if we look at the comprehensively, when patient presented with this, the lens was subluxated. There was no, this was the repaired. We did the lensectomy and tried to use the sulcus fixated lens, could not do it. We removed the lens, did the vitrectomy again. You can see we have done the scleral tuck lens. And child is doing well. So this lens is OmniFit. It can work in any situation. This was the traumatic lens drop. We did the vitrectomy. Patient had a secondary glaucoma. We did the peripheral iridectomy also. And later on, we did the scleral tuck lens. This again is a subluxatory lens. And, we may use the irrigation using the trocar, or we may use the this patient had almost aniridia with very disfigured sclera. It was a zone 3 injury. Patient has a 660 vision, and we are planning to do the iris prosthesis with this. These are the results which we published, one in IJO and one in the other journal. So we recommend all of you to consider any disfigured eye, any bad wound where the vision can be retrieved, we can regain the vision, and no eye is no salvageable, even no PLIs. We published the data that in 29% no PLI, we can regain some vision. So important is, despite of all techniques and technologies, we need to prevent the injuries, because 100% it is a preventable injury. How we can prevent? Very important awareness amongst the community, but it is very important to have a awareness amongst the general and medical community. When we receive a severely traumatized patient, many ophthalmologists must have told those patients that nothing more can be done. But then we see that there is a important there is a regaining of vision. So large number of general ophthalmologists to be trained to deal with ocular trauma. At least you can guide some people so that they can regain vision, and if patient present late, then visual recovery chances are less. More number of ocular trauma care centers should be there. Thank you. Thank you very much.
Thank you so much, sir, for that lucid presentation. It was like viewing an encyclopedia on ocular trauma, and in particular, the open globe injuries. And a personal learning.
I think you are muted yourself.
Pardon, sir?
Yeah, fine.
Thank you so much, sir, for the lucid presentation on ocular trauma. It is like viewing an encyclopedia, particularly the open globe injuries. And congratulations to you on such a beautiful compilation of all such videos on ocular trauma, viewing all the scoped area and all the vast extensive cases in open globe injuries, sir.
Yeah, Dr. Purendra is there?
Yes, sir. I guess is this. Good evening,
Yeah.
sir.
Yeah, and they're very good evening.
He is much more expert than me on this subject.
No, Dr. Mehul, I could see your compilation of cases, your presentation, everything was very good. And your studies, various studies and different journals, I really respect you and admire you for all the things which you are doing in a meticulously and in a perfect manner. And at a small place like yours, Dahod, you are doing wonderful work, and you have made an institute in such a remote place single-handedly. Both you and Dr. Shreya, you have done a wonderful job there, and we are your admirer. But
we are working together as an ocular trauma society. So I think here in the panel, Dr. Purendra is there who can give the comments on this. Rather than giving comment, if we can have some question, that is better. That we can clarify the question. Right, sir?
Do we have any questions?
Yes, sir. We have a few questions from the audience, sir. The first question is, how does the tenon tissue heal in a penetrating lobe injury?
How does the
tenon tissue heal?
How does the tenon tissue heal?
I mean, it is a part of it in younger and middle age and elderly age group. Tenons behaves separately, differently. What I feel is, in pediatric age group, we have to make it repair it or just adhere it separately along with the conjunctiva. And in the elderly age group, the tenons becomes very, very thin with the advancing age. So then it is not much of an issue. But in younger age group, in pediatric age group, it is quite thick. And we have to bring it and bring it close, and with the help of cautery, we have to seal it.
But in intraocular injuries, we are more concerned about the vision and regrowth of the membranes behind the lenses and in the media. So rather than external healing, that hardly matters. That matters when the patient develops the secondary glaucoma and we need to do GDD or some other surgeries. Then the tenon healing problems will be more important.
But separately, I don't think tenants create any issues in a case of a trauma anywhere.
Right.
Whether it is
Anyway,
unless
zone
it
3.
is, if you instill lots and lots of fluid or lots of liquid, then it just swells up and then it imbibes in the wound. Otherwise, it doesn't do anything, especially in pediatric.
But important is if it is zone 3 injury, then anyway we'll get the fused conjunctiva, tenons, and when we are going for either glaucoma surgery or retina surgery, we need to dissect, because many of the time zone 3 the sclera is very much disorganized. We may need to put some buckle for retinal tears. So then we need to dissect. Otherwise, we don't have to worry about tenons. Not in the traumatic cataracts.
Yes, sir. I think that answers the question of the particular student who has asked the question. Second question is, what is the minimum time frame needed between a primary repair and a secondary surgery?
Secondary IOL surgery.
Yes,
you mean to say?
Cataract surgery.
Cataract surgery or but I think we should wait. What earlier people used to say that we should wait for 6 weeks, but I have seen that even at 2 weeks, if the pressure is rising or the flocculated lens matter is creating trouble and creating reaction in the anterior chamber, then I think we can go early and remove the cataract and do the lens implantation as per the status of the capsule.
Yes, correct. Is 2 to 3 weeks, I think, is proper time.
And
that's what our study reflected, that between 15 days to 30 days is the optimum outcome. That's a study we published in EJO.
To prevent amblyopia, also you should intervene as after clearing all.
Earlier, people used to say earlier studies were saying that 4 to 6 weeks, or we should wait for 6 weeks. But now I think earlier intervention is better, and after 2 weeks we can do this second surgery.
Right. The third question is, what are the points to be evaluated when there is a uveal tissue prolapse through the wound site?
I think we have covered that. If patient is coming from long traveling distance, if more than 24 hours are passed, if the object of injury seems to be infected, like wooden stick or some you have to take the history of the settings. You think that if the iris tissue is contaminated, then we need to sacrifice the iris tissue, or else we can reposit the iris tissue.
Yes, sir.
The texture of the iris will tell us whether it is healthy or whether it is mutilated or it is infected, and we'll decide whether we have to repose it or we have to abscise it. And because on table you can decide, because I have, in a sterile condition, if non-infected condition, even after 48 hours you can reposit the iris, because this iris curtain is very, very useful to decrease the glare halo, even if there is a damage to the sphincter and dilator muscle. But the diaphragm itself is very, very helpful. Presence of the uveal tissue.
Yes, sir. So the next question is, what are the differences in our approach in a globe injury resulting from a penetrating trauma versus a globe rupture following a blunt trauma?
I think there is confusion. So if we consider the open globe injury, there can be two subcategories for penetrating injury and globe rupture or laceration. But blunt trauma, we don't need to repair, right?
Yes, sir. They've asked, following a blunt trauma, if there is a globe rupture,
right,
then what is the difference in our approach?
So what we do is, in penetrating injury, the openings are usually so small, we may not need to repair. Like if it is a needle injury, we may not need to repair. And for globe rupture, we can repair the globe rupture, and after 2 to 3 weeks, as we discussed, we can go for traumatic cataract or any other posterior segment pathology.
Repair principle and will remain the same. Principle of repair will not be different. Mechanism of injury is different, and but the principle of repair will remain the same, as Dr. Mehul has demonstrated in his talk. They will remain the same.
And so one of the students has asked, is there a particular size for performing a primary posterior capsulotomy following repair surgery in a traumatic cataract?
I don't think there is size, but we have to understand that if it is a acrylic lens, it has got tendency to fall down through the bigger capsular axis. So better not to create very large size. Okay, you have to restrict yourself to the smaller size for the optical correction as well as for viewing the posterior segment. If we create very large size, then in our cases also, we have seen many of the lens drops happening through that opening.
I think 3.5 to 4 millimeter size is adequate. And if it is central, 3.5 to 4 millimeter size PC opening is sufficient enough. And hydrophilic lenses, they have a tendency to fall back through the opening if it is large enough.
If it is 3-piece lens or a PMMA lens, it will they are more stable.
Yes, so 4 millimeter is fairly good in size, even in pediatric age group, and the chances of the development of the membrane from the periphery and restriction of this opening is also less.
Yes, sir. One of the viewers has also asked, what is the difference in our approach when we see a differential subluxation of a lens? Probably they meant like more number of clock hours of subluxation of lens in a traumatic cataract. How different is our approach? I think that is what the viewer meant, sir.
I think there are algorithms for that. But first of all, options we have to think. The options are lensectomy and SFIOL or CTR ring with the Ahmed segment and IOL. And third, you can do the, if it is a total dislocated lens, you do the posterior pars plana vitrectomy, remove the lens and do SFIOL.
Can I say something?
Yes,
yeah.
Yeah. Look, what the principle says that if it is less than 3 clock hours, then a simple capsule tension ring or CTR is sufficient. If it is between 3 and 6 clock hour and beyond that, then you have to use a Sioni ring or CTR with CT segment and you have to stabilize the bag with the help of Prolene or Gore-Tex sutures to the sclera. That is what, otherwise this capsule bag is going to shift to other side if you have put a CTR alone. And if it is beyond 6 clock hours or more than 180 degree, then you have two options. You try this, fix the globe to the sclera, and if you are successful, well enough. Otherwise, you have to remove the lens completely along with the capsule and rehabilitate this patient with the scleral fixated IOL, glued IOL, scleral tuck IOL, or any type of or retro-iris fixation. That is your choice. So this is how it goes. Along with the
posterior segment surgeon, we would like to do the lensectomy and SFIOL, which is much stable solution, because if it is a large defect in the zonule and then we do something and there are chances that the Prolene sutures are degenerated in long run, then we find the whole dislocation of the whole complex inside. These are also the cases which are all reported.
Yes, sir. So with this, we come to end of the questions from the viewers, sir, and the students who have viewed this. And thank you so much, sir and ma'am, for this beautiful compilation, extensive coverage of ocular trauma. It was a treat to watch. And it was a personal learning point today for me that if there's no perception of light, there's nothing like you cannot handle the eye or cannot operate on that eye.
It is our publication that in Journal of Retina Vitreous that in 29% of BLIs, we regain something ranging from hand movement to the 618, 612.
And the most important thing he showed today is other than using vitrectomy cutter to clean the wound, he has used a newer technique which is AC maintainer. So that AC maintainer is not only prevents infection because the flow is from inside out. So while you are operating, it forms the AC. At the same time, it continuously washing off the things. So that's the beautiful thing he has
Dr.
innovated.
Purendra, I think you are also not using Visco, right?
No, I don't use very minimally. I use Visco, and I use it as and when required.
Right. So Visco is to be
I
avoided.
don't use viscoelastic because
Yes,
but that creates more of inflammation, and if it goes behind, it produces more inflammation, and you get confused whether it is infective or inflammatory.
Very severe secondary glaucoma. Rather than cataract, we keep treating the glaucoma later on.
Yeah, that is there, and inflammation also is it becomes so messy whether to differentiate whether it is sterile or whether it is non-sterile, infective. So that also is a big thing, and you cannot remove viscoelastic completely once you have used it inside. And in the presence of the PC rupture or there is a single chamber, then it becomes still more difficult in a single chamber cases.
Is a disorganized globe and you don't know which other pathologies we are dealing with.
Correct.
very true, sir. Very true.
Right.
Okay.
Thank you.
May I request
you.
Purendra, Bhasin sir for any concluding remarks on this talks?
I think he has covered, Dr. Mehul has covered very nicely all the aspects. And I thank Dr. Mehul and Dr. Shreya for being with us. And the trauma is very interesting. Most interesting thing in ophthalmology, what I feel personally. We should not feel that trauma is less rewarding or it is, more challenging. Rather, trauma gives us the adventurous part of the science which we get out of this, because every case is a different case.
Unique case.
We would like to use your platform to appeal all residents and young surgeons to be part of the Ocular Trauma Society and be member. They can contact us. Because if you are in that this type of communication, then obviously it will create awareness about the newer technologies available to treat the ocular trauma.
That's true, sir.
So we appeal all of you and all the students to be part of the Ocular Trauma Society.
I'm sure after watching this lecture today, many residents will sign up for the OTSI membership and be an active part of the society. I really
Thank you.
They can come for fellowship also. They can learn.
We offer fellowship 6 months.
Dual advantage. They can learn the routine cataract, phaco, and glaucoma, retina. And apart from that, they will be getting an exposure to the management of trauma also.
We have a provision. We have a provision of fellowships with any other regular fellowship. If you extend for 6 months, the Ocular Trauma Society awards the fellowship certificate to them. I think there are a number of institutions which are all listed on the website.
Our website and in IGO also.
Yes, sir. A small announcement for the next week, sir. We meet next on 30th of November, and the topic would be posterior segment trauma in a retained intraocular foreign body. And the speaker for the day would be Dr. Sangeet Mittal.
Right.
Right.
And another small announcement that iFocus Physical is back, and it will be from 26th February to March 5th. And we have limited seats, only 300 delegates. So hoping all of you have registered. If not, then please register on the link given here. Thank you so much again to all the chairpersons and Mehul Shah sir for the lecture today. And
thank you so much.
Thank you.
Thank you, Dr. and Dr. Shefali. Dr. Purendra, sir, you have already extended your time. Thank you so much, sir, for being with us and
Thank you all.
Doctor, thank you, CFS and Dr. Santosh.
Santosh on our. Thank you.
In
He's
both
doing
of you. Thank
tremendous
you.
work training residents.
Thank you, sir. We'll definitely communicate this to sir. Sir is traveling this weekend.
Yeah, we understand.
Even though he was busy today, he had sent his message that for today's meeting, he wants to be excused. But probably he'll be there with us next weekend.
Yeah, thank you.
Thank you. Thank you, Sugar and Shefali. Thank you so much.